So what you should remember is that initially in the first couple of appointments of pediatrics, you all took, or even in medicine surgery, you took mainly a system-based history. That is where you took each and every detail from the patient and tried to see whether there is any abnormality in the systems. The whole idea is because your knowledge about formulating a quick diagnosis or differential diagnosis with the presenting complaint was not very fluent, was not very conversant. So your knowledge base at that time was not very broad. But now with time, you all now have come to the final MBBS and already you have done 2 appointments. And basically, what were the previous 2 appointments you all did?
Surgery and gyn and observation.
So some amount of history is rather narrow in those 2 cases. But in medicine and pediatrics, it would be much more broader histories because the complaints are not focused and vague and for you to get into the system. So having said that, once you get the presenting complaint, you will have some idea. So what in the past was done, patient was identified, that is basic always. Then they come up with a presenting complaint. Then you take a narrative history from the beginning, okay, what happened at this particular time, and then chronologically move forwards. Now, one thing you have to decide on which way you are going to make this chronology happen. That is whether you are going to use by days, hours, or dates. Now, for example, if it is a neonate who comes with jaundice at 48 hours or 72 hours, it is always better that you narrate it with an hourly basis. Because at birth, it was this time the child was born, then 5 hours later, this was detected, what like that, because it's a so short history. But if it is something like a respiratory tract infection, diarrhea happening over the last 2 to 3 days, then of course you can say on day 1 it happened like this, second day these were the symptoms, like that. If it is a long history, a undiagnosed fever, something like that, or even a cerebral palsy, seizure disorder, then you can say, okay, it happened on this particular day, 3 months ago, or calendar date, and then relate it 3 weeks after this happened, thing like that. Or you can say in month of January this happened, started, then in February he was well, then by March, early March again he fell ill, like that you can get. So all that depends how finer you have to go into the history and the details and then adjust your time. But don't try to mix that. Now don't say 3 days ago or on last Monday he developed this, then 2 days back he had this symptom developing, like that. You don't mix the calendar dates and the chronology of the time. So just stick into one type of a pattern and try to move forwards rather than trying to move backwards. So you can start and take the person 5 days back into the onset of illness, and then from that point taking as 0, you move forwards, telling, okay, first day like this, then 24 hours like this, again another 18 hours after this happened, like that. Then you will have the past medical history. Now the thing is, you may not know exactly what or knew those days what you were dealing with. So then you will ask every sign and symptom pertaining to the respiratory system, cardiovascular system, CNS, GIT, like that. But I will tell you now how we improve on that. Then, of course, definitely the birth history when it comes to pediatrics. But again, you don't have to go into great detail of the birth history of each and every. Where you have to see what it is the most important. Now, if a 14-year-old or 13, 12-year-old comes with dengue fever, you are not going to tell about anything about the birth weight unless it was really complicated.
Recording stopped.
Right? So the important thing is that you have to see
Recording in progress.
What is the relevance of this birth history to this particular condition at the moment. Of course, obviously, it is important for that individual, but whether it is important for us. Now, if it is a 7-year-old coming with cerebral palsy, still the birth history, perinatal period, what happened is important. But even a 3-year-old coming with 3-day history of fever and cough, and you are quite clear, you can just say, okay, the birth was uncomplicated and the birth weight was this much, because there is an important component for the growth of the immediate, because still the prepubertal growth, the birth growth or the birth weight really matters. So like that, you have to decide what is the depth based on the importance of that particular information to the particular current condition which you are supposed to manage. So then the immunization history, obviously you have to know, because that is part and parcel. Patient may not come and say that they have missed immunization. It is our duty to pick up. And also remember that you have to see whether the BCG scar is present, as well as whether the BCG scar had been documented in the CHDR. Because if that is not there, and if baby is more than 6 months and less than 5 years, within the hospital, you should bring it to the notice of the others and get the immunization sorted out. Because you all know, if there is no BCG scar and the CHDR has not documented that, that means he had never had the BCG scar. So those people, children, need to get a BCG vaccination. So these are little things that you have. Then development history again, if it is appropriate, yes. But of course, if there are problems, then you have to go into great detail. Then dietary history. Now dietary, of course, nobody expects you, even from MD pediatric person, a 24-hour dietary recall with calorie content looking at it. I mean, what you have to mainly look at it is whether there is adequate variability in the diet as well as the quantity, and especially whether the time periods are adhered to correctly, because sometimes they give very erratic time periods. Sometimes the breakfast is given at 9 o'clock or 10 o'clock, and then lunch at 2 o'clock, 3 o'clock, and they will say the child is not eating. Child is not eating because there have been no proper gaps between the feeding and no proper schedule for the child. So those are the things. So mainly concentrate on the volume of food, then the variety of food, because we know that you all have studied what is called the food-based dietary guidelines, looking at 6 food groups, and there should be adequate representation in all meals. That see whether that is there. And then, of course, you also have to create a discipline, proper time schedule for them in order to have a proper meal. And then they should not be going on grazing and binge eating from time to time. Then obviously the family history, drug and allergies you have to find out. And then the social history, especially in this time and era, there may be, because there are a lot of people who are willing to donate, and there are systems also in the social services system of the government of Sri Lanka. People out of ignorance may have not known, and sometimes the house officers, registrars may not be able to also provide that information because of the busy schedule, they may forget. But you all have much more time. And of course, your previous group had done a lot of help to many children and students in the past. But then, of course, that has to, simple things, you can direct them, ask them to, you don't have to do everything, but you can at least provide the information they require from where to seek help. So that type of thing. So that is why all these components are important in your history taking. Now, but this will take a long time because you are doing a system-based clinical history. So what you were taking was totally important positives and negatives. Now, you can't go on like that. And so initially what you had been doing, is a system-based clinical history where all the important or whatever the patient was telling, you went and gathered the positives and negatives, and then you have to formulate a problem list and arrive at a diagnosis, a differential diagnosis. So definitely most of this now you have been able to do. But probably still sometimes we see you all still revert back to the system-based history taking or narration, where you give us all the information which may not be really relevant to this particular patient's condition, especially the irrelevant negative findings. So then, because of that, you have to move into a problem-based clinical history taking, that you go for the problem and see. Now, the problem is mainly a presenting complaint, which the patient comes. Then once it is given, you have to focus yourself to which system possibly this condition is related to. Because there can be multi-system or different system getting involved. Now, for example, there can be headache, but it can be actually some of the psychological thing on one hand, or it can be abdominal migraine giving rise to a concomitant headache also, like that. So for that, you have to see that. Then at that time, you may get a possible differential diagnosis also formulated, depending on the duration and all. Now, if somebody comes with a 3-month history or 6-month history of headache, it is unlikely to be a fast-growing tumor. If at all, it could be a benign space-occupying lesion. So like that, you have to think. Now, so when the presenting complaint comes, and then the possible differential diagnosis or the presenting complaint, then your part, you will try to fit it into a particular, direct yourself to a particular system. So based on that particular focus, you will try to formulate the possible differential diagnosis. And then what you will do is, in your history, you will try to see whether what weight you can give for this particular, what is the possibility of, for example, we can see it's a diarrhea. Then the diarrhea can be due to some CNS problem, or it can be due to GI problem. And then you have to ask questions directed whether which system this could be possibly the reason for this particular symptom. So then use hypothesize. You see, okay, the headache the abdominal pain and must be due to a gastrointestinal infection. Then you will ask questions, okay, the bowel motions, what is the consider, how is it, whether there's tenesmus, things like that. Or whether it is due to something else, whether it can be malaria, whether it can be meningitis, like that. So you have to see the symptoms and based on your differential diagnosis, you have to take or direct your questions. So that is where you are moving away from your system-based history taking onto a problem-based history taking. This way you will be directing more or less. Sometimes you may ask close-ended questions, because if you give open-ended questions, you will never have time sometimes, because there may be people who really want to talk and keep on talking, which you will not gather much information. So after a point, you may shoot at them with close-ended questions and try to get the relevant answers to either accept or favor one of your differential diagnoses, or put less weightage and refute some of your differential diagnosis. So that way you have to see what you are going to be. So for example, again, going back to presenting child with headache, it can be a short duration where if they come with a 6-month history of headache, then it is unlikely to be a infective cause like meningitis or malaria or something. But if somebody comes with fever and headache of 3 days duration, then you have to think of whether it could be something like dengue fever or meningitis. So like that, you have to focus yourself onto that and then have a differential diagnosis possible. Sometimes at the end, it may none of those, but a totally different diagnosis. But never mind, you have to think this is the possible things under the information what I have gathered. So based on that, you have to move. Then you will hypothesize each of those and then deduct or the ones which are not going to really fit, and then give the more or take up the more fit, the ones which will fit better. So here, so going on to the problem base, the patient identification data as they are presenting complaint, identify system area or hypothesize a DD. Then in the presenting history of presenting complaint, again, important positive and negative information should be gathered to hypothesize and formulate or to affirm your diagnosis or to deduct the certain differential diagnosis you have given. So the past medical history will be there, all the other components. So the systemic inquiry will go off. So the weight for each of these, as I told you earlier, also differ. And also whatever information you gather, you need not be telling to us, presenting, because that may be not very important. It is just only passing by information. But you may have had asked about that, because that will help you in gathering something, and maybe even a total unidentified problem could crop up and you will be able to help them. So remember, as I told you, all these components should be there, but what is important is, are you going to give each and every component a detailed outcome out of that, or it is just only the relevant bits, or whether even sometimes you may drop out certain sections which are not going to give you any information. So then you will go on to the examination of the system. So the general examination, and then you go for the relevant system. So the cardiovascular, respiratory, all that is there, but you first focus on the system where you think the primary problem is. And then general examination also, you do the relevant examination for that particular system or disease, not that you do an entire thing. But of course, certain things like scanning the skin and see whether there are any patches, any discolorations, any wounds, that type of thing is important, but you will not spell out each and everything. So the other thing is, in all your patients, because you get only very limited number of patients and limited time now. Because of that, it is sometimes you may go without seeing many systems. So my advice is, after you have, so you concentrate mainly on your relevant system for that particular. Take the history on the day one, because you are not spending a lot of time in the ward. Own benefit, and you can actually present even to your friends. This way you can learn and practice. Because if you have not practiced, don't think during study leave time then you can make sure that you have got it, and then during your study leave period you can just brush it up and improve on that, because now specialties also. So make sure that you get the maximum out of this, and the number of patients would see the other patients also at the convenience of those three patients, but don't try to make sure that you have taken proper precautions of cleanliness and everything. Itself, you start your examination. That is, you observe the child and the child mother. Need not do at all, where you will be seeing what there. If the child sits on its own, if the child picks up a cube and build it on it, or if you can see that he picks up a small piece of paper from the side of the bed sheet or even a small thread, if it becomes picking up in a pincer. Because if you try to do it, they sometimes may resist it because of the anxiety. And then you will come up with a false negative to the level of the child. So can anybody tell what I meant by getting down to the level of the child? Down to the level of the child.
As a child,
Same.
mind
Yeah.
as a child.
Develop at that time common interest. If there is a book, you can that. Then the other getting down is physically you have to get to the level of the child, because if the level is maintained at the eye level, then of course it's very easy. So sometimes high beds like in adult wards, so you may have to even knee down depending on your own height. Metaphorically as well as literally. Cardiovascular system, you tend to examine as if it is a totally dead body, right? You have to eyes of the child, you have to make faces, you have to smile at the child. And during the appointment, it will come natural to you. But ultimately, what will happen is you will have one checklist item in your head at the end of that to the examiner. So that's why all those things, I mean, that will not make you lose marks. May not be overlooked also, because when you look at the artificial. So what we all discomfort in you, we are also confident that you can go to the society, go to the field, and you have to gather during this 8-week appointment. So that is the most important, because don't think I have to come and study here. No, the 4 hours time to study your theory. But what you should do with the appointment is you should examination, your auscultatory skills, as well as your soft skills of speaking to people. During this time. So then you also should know how to soothe a crying, irritable child, because that is also important. So then the growth assessment, all allocated patients, you have and also to calculate the BMI. Then you have to properly plot these things of the department, Padma. No point. Or height is this much and stands between -1 and -2 and -3 standard deviation. No, that all. And also remember, all children below 5 years, you should know the weight is just only a weight for age, just only a normal screening tool. Where this child is then all the children, the BMI and make sure where it is. And then you have to go beyond that. So you all are very familiar, and my information now, and I will definitely question you on those things during the appointment with me, right? Because there is no point. You can't train them, you can't advise them. You will look like a laughing stock. If you right? Okay, so these are the charts. Whole set of charts, which of course are not unique. The nutritional assessment, breastfeeding, describe the technique, identify common problems and their solution, pay attention to mother hydration and nutritional state. Obtain a diet recall who are receiving supplementary food formulating individual feeding plan. Now, the dietary recall, you don't go into create a detail of the the frequency is important, the variety is important. So the timing, the frequency, the variety, and the quantity. So those have to be given in detail. So then once you have taken the history examination, then you have a management plan. So you formulate a problem list. Now don't say fever is a problem, cough is a problem. All that you have to collectively and say, okay, there is lower respiratory tract infection, no upper respiratory tract infection. Because each component now within that you have to manage. Because if you are managing pneumonia, you know you have to manage the fever, you have to manage the hydration, you have to give the antibiotics, you may have to start on physiotherapy, bronchodilators if needed, mucolytics, all that. So you don't have to say there is tenacious mucus, there is fever going on, there is post-ossive vomiting. That type of thing is not relevant. What is relevant is large, differentiated problem list. So once you have a problem list, you should not be trying to find out a final diagnosis definitely. And especially in a 40-minute encounter, you can't come into a diagnosis most of the time. And nobody is going to penalize you, because our interest is to make sure that you make the patient and keep the patient alive, comfort the patient, and then try to sort out the problems one by one. So within that one by one problems, the diagnosis could be one thing. Because if the person is having a simple diagnosis, but of course has a lot of other problems like maybe psychiatric or psychological problems, malnutrition, things like that, you can't forget, and you can't say, no, the patient never complained that the patient's weight was not enough. No, we have to see those things. So that is where the problem list is the most best target, and you should try to target for a problem list. And once you have sorted all that, normally, immediately, your and the disease would get also controlled. So analyze the history and examination, reach a diagnosis or differential diagnosis, plan out and initiate the relevant monitoring. Now don't say I'm going to monitor this child. You have to tell what is exactly you're going to do. Because no point, no, monitoring can be various things. If it is a nephrotic child, then you will monitor the weight and urine output and urine protein urea. But if it is a dengue child, you are not going to look for the protein urea. You will be monitoring at the pulse, respiration, BP, and then urine output, thing like that. So you have to tell what exactly I will be monitoring these parameters, and monitoring itself is not enough. You have to say the monitoring is done at this frequency. And also actually you have to say my threshold points or alarming points are this. If you say, okay, at 0.8 milliliters per kilo per hour urine, I will look into the reasons and try to take remedial action. Pulse rate is going up to 120 at that time. So you can say, I've been checking the pulse rate, respiration, urine output, and at these points, I will be asking to be informed to me, because once you are becoming doctors, you can't be doing each and everything. You have to, because sometimes what happens is monitoring will go on. And as somebody recently said, pulse pressure, when the pulse is also 40/30, still the monitoring going on. Nobody has informed. So that's why you have to put the flags at the correct points, and also mention in the PhD, this has to be brought to the notice at this level. And there should be buffer. You can't wait till the urine output falls to 0.5. So you have to act or be conscious about the problem much earlier than that. So you have to keep about 10% buffer zone for that. Then plan out the relevant investigations. Don't do everything under the sun. You have to make sure that what you are doing is relevant, because somebody has to pay. And on top of that, the time of the ward staff will also be unnecessary. Sometimes you may not need a blood sample, but habitually you will ask. Dengue patient who is recovering, now last 2 platelets have come up to about 45, from 35,000 to 45,000. Now in another 12 hours doing it may not be the best thing. You can wait a little and do. So all that you have to decide. You have to identify the medication and check for the doses. Now don't say that this was given. You have to see whether this particular medication is the correct amount. And I have always said, you have to get to the level where you will give a rounded up figure. You don't prescribe 153 milligrams of paracetamol. You don't prescribe 235 milligrams of amoxicillin. You have to see whether it can be given. So get into that habit now itself, then it will be very easy. Formulate a problem list, analyze and make a diagnosis or differential, plan out the management, formulate a summary. So at the end of your 40 minutes, you should be ready with most of these things. And then, of course, you have to continue care. Now you are dealing not at the exam. Now you are going to see these patients daily in the hospital. And unfortunately, you all are not doing two ward rounds these days, only 1 ward round. So at that time, you have to maintain your notes. Don't say that I have seen this child in the morning, because I will be asking for your daily status notes. Because that habit, my job is to make you learn these things and get it to the habit and practice it in future. Because you will not be taking this degree and going and doing some other job. No, 95% or 99% of you all will end up doing clinical work. And then postgraduate, it will be again at least about 70-75%. So that what you learn here, it should be, the basic should remain to your entire life. So if you don't get that, then of course, irrespective whether it's pediatrics or surgery or medicine you are going to do, your clinical habits, because what you are at the moment is doing more or less every specialty, same clinical habit. Daily receiving a patient, taking a history, doing examination, developing a problem list, and then managing the patient in the ward and caring and continuing at the ward and then discharging plan. So all that specialty will be different. But of course, you can't say I want to do medicine, because of that, no point of this. But the crux of the Theory material may not be that important, but anyway, you have to pass your final MBBS before thinking of postgraduate. But the habits you develop, taking notes, keeping notes, signing, putting the date and time, all that matters in the long run. So try to develop is not redundant. It will not take any space of your brain, but it will make you a much more perfect person who will be comfortable as well as upheld by your superiors in future. So observe for salient changes related to the illness. Don't just say his respiration is this, pulse rate is this, like that. You have to see whether if there was a swelling, cellulitis, whether the swelling has come down, whether he's comfortable, whether he can walk, bear weight, all those things. Then, so all that need to be done in your daily status. Then, of course, discharge and follow up again in your and then whether it is a feasible, executable plan or is it not necessary. Because sometimes some patients we have been unnecessarily asking them to come to the hospital for the review. Now a dengue patient who is platelet count at discharge is 105,000 or 120,000, no comfortable, no elevated ALT, ASTs. You need not get them down because especially in this time and era, even other times, you should not get them. Here the human cost is too much. Other times the financial cost is too much. Now here, now in these days, the financial as well as the human cost is huge. So don't get people out of their homes unnecessarily. So see what the discharge summary is, then formulate a follow-up plan and educate the parent-patient guardian on all those things. Because once you say something, it will be well accepted more than someone else telling them, because you all are respected medical students. Any questions up to now? Any questions? Any questions? Hello? Can you hear me?
Yes, sir.
Yes, sir. Didn't understand a bit. Clear?
Yes, sir.
Yes, sir. Hopefully. We'll see. So you have threats here. At the end, what we are interested is you all leave this place as a complete with a reasonably good knowledge on pediatrics, develop skills on pediatrics and develop good. One thing about IWC, your presentation should be focused to the patient. Now, don't try to give a theory, theoretical, what do you say, lecture on a and for this patient, how are we going to apply? Right now, for example, if it is a dengue patient, you have to say, this is the fluid volume I'm going to give. This is how it is going to be given. Things like that. Don't say, and you have to give it to the calculated to the individual. That's why I say, don't tell, because now what has now, you all were taught the individual person to apply this. So you can't come and say, I will give 10 to 50 milligrams of paracetamol to this patient. No, because you are not going to write to the pharmacist to decide on that. You are going to say, I'm going to give 120 milligrams of paracetamol, 6 hourly PRN to this child. So like that, you focus everything to this particular individual and then give it. Now, like that. So in the IWC, converting it. That at the end, you should not be giving a whole heap. Actually, no need of giving a lecture of the topic at the end. You just incorporate. It's clear for you.
Yes.
Yes.
Right. Guidelines, and definitely what you have to do is don't eat collectively in a place, right? Even if you have distance, make sure that you are totally not facing ill unexpectedly, unnecessarily, because I mean nothing will happen to you all, but it causes. And for us as administrators from the faculty side, the dean is really stretched. We from the clinical sciences team are really stretched. And we want to see you all leave this place as soon as possible. So just make sure that you play your individual part, right? If there's any issue, always remember to just come and talk to us. Okay? Right, thank you.
Okay, thank you very much.